see. Hi, Martina. Everything is working. So today, Ellie, the vice chair of the organizing committee for BBMS, was supposed to be introducing Martina, but she unfortunately has a fever and a cough, and we told her to self-isolate. And so that's what she's doing currently, but she is watching. So I'm sure she'll have some questions for you afterwards. But as a quick introduction, Martina is a clinical senior lecturer in psychiatry at Imperial College London and the honorary consultant psychiatrist in the West London Mental Health Trust. During her time at the Oxford Cognitive Therapy Centre and the MRC Cognition and Brain Sciences Unit here in Cambridge, she developed a specific interest in the role of mental imagery techniques in regulating emotions and further seeks to translate her work into customizable interventions enabled by digital tools. So very in line with what BBMS is trying to showcase. Today, she's going to be telling us a little bit more about herself and the innovative app, Imaginator, that she developed to support young people who self-harm. So I hope everyone thoroughly enjoys Martina's talk, and it's over to you.
Thank you. Thanks a lot for inviting me, and well done, guys, for so quickly moving this to the virtual space. So let me see if I'm successful at sharing. There you go.
Yeah, looks good.
Okay. So I'll be perhaps giving you a slightly more traditional medic style presentation. So a little bit about me. Before joining Imperial, I was actually in Cambridge for 4 years, and what I'm going to talk about is work that I developed in Cambridge when I was at the MRC Cognition and Brain Sciences unit, and also as a consultant in the first response service, which you might have heard of or be familiar with. And what we developed was a new, what's called a blended digital intervention to support young people who self-harm. So an intervention that puts together a smartphone app and a more traditional face-to-face therapy. What in general, what I've done through my career, which maybe might be of interest to some of you in the audience, is I've always sort of tried to work at the translation level. So from observing the phenomenology, and in my case of emotional disorders, trying to unpack that in what are the building blocks to understand the mechanisms, and try to develop more mechanism-based interventions, which can be drugs, but can also be psychological interventions, and this is developing mechanism-based interventions in psychiatry is particularly challenging, because there is not such a good understanding yet of actually what is the underlying psychopathology. And more particularly for me, I've also tried to do this sort of building bridges across disciplines. So I'm a psychiatrist. I trained in cognitive therapy, so actually a lot of what I do might be more traditionally familiar to experimental psychology. I've worked with neuroimaging, and more recently I developed an interest in actually not just innovative interventions, but how to bring these in the digital space. So I'll present you the results of an initial study, but hopefully I'll tell you a little bit also about the process of how we built this new blended intervention. So a bit of background on the actual condition target that we wanted to help with. Just so that it makes more sense. So you might be familiar with self-harm, because it's a behavior that is also very much, let's say, become on the front line of the media and so on. It is an act of self-injury, irrespective of the purpose. But the way it's most often described by those who experience self-harm is something that relieves of a terrible state of mind. It can have very heterogeneous presentations and also motives. So what we know that most young people who experience self-harm will actually stop doing it, but approximately 1 in 5, for 1 in 5, this will become a repetitive behavior, and will also increase severity. And it's often associated with symptoms of anxiety, depression, substance misuse, but it's not exclusive to individuals who have a diagnosable mental illness. So what we would say is that it's actually a transdiagnostic behavior. What is important is that actually it's associated with poor health and functional outcomes, and is the highest risk factor for attempted and completed suicide. And we have no good means at the moment to identify of those who self-harm maybe once or a few times, who are the ones who are going to repeat self-harming and who are most at risk. Hence, it is important to have interventions that might help everyone who presents with this behavior and who asks for help. And if you're familiar with some of the data, like even the UK data, the morbidity surveys, actually in the last years, the prevalence of self-harm has increased, and it's probably now about 20-25% in those around under 25 years of age. So when we developed Imaginator, we had a particular, let's say, clinical challenge in mind that was coming from what are the current treatments that are available. There are treatments that we know are helpful for self-harm. These are all psychological interventions. But most of those who are evidence-based and where the effectiveness has been replicated are quite long and quite costly as well. So, for example, one of the interventions is called dialectical behavioral therapy, which has been found to be effective in a couple of good trials. But this is a group therapy that has at least, say, 15 sessions. So, and also most of the trials have been conducted in specific populations. So perhaps young people who have already a certain diagnosis or who may meet a threshold for being supported by secondary mental health teams. And as you may imagine, this is not the case for most of those who actually experience self-harm. So while we have some good treatments, these are not generalizable, and they might not suit all of those young people who want support and want help. In fact, there is data saying that only 1/3 of those who self-harm will ask for help, and it's unlikely to be from traditional mental health services. So what we wanted was, can we develop an intervention that is transdiagnostic, is not suited just to one clinical presentation, who is able to reach out to young people who maybe don't want to go to traditional health services, who's short, easy to deliver in different settings, but also who might, an intervention that might be a tool to help young people self-manage and regain control, not necessarily just receiving help from someone else. And most of the interventions nowadays focus on what's called emotion regulation in terms of mechanisms, but they don't work for all. So we're also thinking, can we focus on a different mechanism? So briefly, let's say the phenomenon and the tool, the cognitive tool that Imaginator works with is mental imagery, which is whenever you see something in your mind's eye. So usually if I had a live audience in front of me, I would ask them, picture the front of your house and how many windows does it have. And I could see most of the people perhaps just for a moment closing their eyes, because that's what you do if you most of the times if you need to imagine something. So this is mental imagery, and it's just a cognitive function that we use very normally. Now, what we do know is that, and why it's relevant to self-harm, is that very often when somebody experiences this self-harm, they also experience mental images right before self-harming. And this can be images of actually hurting themselves. And we also know that depending on how this imagery feels, it might lead lead more or less to engaging in the behavior. So if a picture feels of hurting yourself is distressing, it might stop you from acting on that picture. But if it's comforting, it might actually make you feel more likely to engage in this behavior. And this is true not just for mental images of self-harm. If you can think about when you experience mental images, that they might sort of be a driver of whatever behavior is encapsulated in that image. And sometimes people also experience images that are simply negative and emotional images that can amplify whatever negative emotion triggers that self-harm. So not just images of self-harm. So this was the one of the reasons for us to think that mental imagery could be an important tool in developing a new intervention. And now, as I was telling you, you might experience mental images before doing anything. So this is very common in sports psychology, imagining, engaging in a certain particular behavior. But what we know is that actually imagining something that is rewarding will make it more likely for you to engage and to try to achieve that goal and to engage in that behavior. So images have an emotional punch and have also a motivational punch, and we can use this for for sustaining an adaptive behavior. And there is imagery-based interventions now, for example, to help people stop smoking, eat more healthily, exercise, and so on. So in a nutshell, we knew that imagery is dysfunctional and can play a negative role in self-harm. And we know that imagery can instead help more adaptive behavior. So what we wanted to develop is an intervention that helped young people use an alternative behavior to self-harm when they were feeling distressed by using motivational positive imagery. And why did we want to combine this with a digital app? There were two reasons. One is because imagery, you can, while we are thinking of conjuring imagery in our mind, this is also helped by actually seeing pictures. And so having the support of a digital app where you can see some of the images, some of the positive images that can help you do something else, seemed like a good idea. And then when I was having meetings, for example, with the NIHR Young People Advisory Group and other groups of young people with lived experience, they seem to say, yes, this makes sense. We're always on our phone. It makes sense that actually using a smartphone app might be helpful. But you'll see by the end of the talk that actually this is not a given, and that it's not so straightforward to develop apps that will actually be helpful. But anyway, what we did is that we developed the app with a group, young people advisory group that had lived experience of self-harm themselves, and AppShine, which is a small company that was actually based in Cambridge. So we had probably over 3 months, 6-7 meetings all together, where we went through the rationale that I've just explained you of the intervention with the young people and the app developers, and tried to hear what everyone thought about it and build it together in an app. So I don't think it's so relevant to know the protocol of the study, but all I wanted to show you is what we actually did. We had 2 face-to-face sessions, and then after that we gave young people the app, and we also had 5 support calls, and we compared this to a waiting list. So this is what you do in an initial feasibility study, where you want to see, is this doable? How would people accept this kind of intervention? Will they come to the sessions? Will they answer the phone call? Will they use the app? So we're not measuring the effectiveness of intervention. It's sort of a first step of a new intervention. So I'm going to skip through this, and I'm going to tell you a little bit what we were actually doing. So in cognitive therapy jargon, the intervention is called functional imagery training. So it it says, it is what it says on the tin. It's about training to use more helpful and adaptive mental imagery, and to change your behavior to engage in a behavior that is helpful via mental imagery practice. So what we were doing in the 2 sessions, we were building motivation to change the behavior by using imagery. So imagining goals, which could be reducing self-harming, but also goals that were about other activities, other well-being aims. And we would use imagery of past successes to enhance this motivation. And then in the second session, what we would do is build a whole an imagery plan of when you're distressed, whatever it was for every individual person, and you feel in a certain way that usually triggers the urge to self-harm. Can you actually imagine a whole plan of doing something else? And how you would achieve this goal of doing something else that will ultimately reach you to your goal of reducing self-harm or feeling better or being able to go out with your friends, whatever it is. And then after the 2 sessions, the app was used to kind of continue practicing the imagery. This is the app. It's not a particularly high-tech app. I hope that we will get funding to personalize it more, but I think the main thing in the app is if you see the icon with the person with the headphones, those are the guided imagery audios. So they're audios of alternative behaviors, adaptive behaviors that were suggested by the young people to listen to when somebody is starting to feeling distressed and might feel like wanting to self-harm. And there's also an audio where you're just guided to actually, it doesn't give you the content of what you want to do, but you're just guided to do whatever you have developed in the face-to-face therapy intervention would be your helpful behavior. And then there's other bits of the app where there's just suggested activities, and it asks you how you're feeling, and based on that it suggests things that you could be doing in that moment to regulate your emotions. So this a little bit about the results. So as I told you, it's a small feasibility study, but what we were very happy with is that we were able to recruit in the study both young people who had been in contact with mental health services, but half of them, a lot of them who had never been in contact with mental health services. So that's all the kind of colorful bit in the pie. So we had 38 young people, different locations in Cambridgeshire, not all of them students. So a relatively representative population. And what you can see here is that if you give them what's a quick diagnostic screening, they seem to tick a lot of boxes in terms of mental health diagnosis, but that's probably an overdiagnosis of this tool. What is important for us is that only 7 were already, out of 38, were already receiving mental health support. So this means that if our short intervention with the app is helpful, it might be one of those solutions that are able to reach out to many who are not currently being supported by mental health services. So again, if you just look at the graph, what you can see there, those are the number of self-harm episodes in the last 3 months of each participant. So you can see a huge variety, which is typical of this behavior. It's very heterogeneous. You can have people who engage in it just a few times over a month, and others who will engage in it daily and weekly. And importantly, so we asked, I told you that we know that a lot of people who engage in self-harm experience mental images. So in our sample as well, most of them reported really vivid and compelling mental imagery before self-harm. And most of the case, it was images of self-harm. And what we saw at the end is that the more you paid attention to this self-harm related imagery, the more the highest was the self-harm frequency at baseline. So What, in terms of feasibility, what we found was that most of those who took part engaged in the face-to-face sessions and at least in half of the follow-up phone calls. So this is promising. Unfortunately, we weren't able to measure the actual use of the app, and this is a big limitation glitch in our study, and something that we will want to do in a full trial. And boiling down, making this slide simple, again, what we found is that there was a reduction in self-harm in those who received the Imaginator intervention, both if they received it straight on or if they received it after the waiting list time. And the effect sizes were moderate to high, so that is sort of, again, acceptable and promising. It doesn't say that this works compared to other intervention, but it says that we should go on and test it in a proper, bigger RCT. So finally, and this might be more interesting to you to conclude, what did the young people think in the feedback interviews? They liked that the focus on the intervention was on imagining goals and alternative positive behavior rather than a focus on what was going wrong in their lives. And they found that this imagery was something that gave them motivation. They liked that they could engage in the imagery at any point. I can do it anywhere and nobody knows I'm actually using one of my positive images. And for some of them, this was quite a new experience. What about the app? And I have sort of left the negative feedback for the app in particular, because I think this might be more of interest to you. It's interesting that some of them were saying things like, well, when I'm in the bad phase, actually, I don't go in my phone. What I used more was the simple imagery that I had learned in the sessions. Some liked the app. They liked the guided imagery audios, but they would have wanted them to be more varied, more personalized. And a lot of the times it was about to figure out when to use the app. So they would say, I wasn't able to use it in huge episode, but I found that if I used it daily, even a little bit, it became maybe perhaps a protective or slightly preventative thing, so that I wouldn't get so distressed. And finally, and this is something that is well known to anyone who's trying to develop digital apps for health, it's very difficult to keep using it. So they would use it maybe whilst we were still having some of the follow-up calls, but then they would stop. So in summary, it's been a very interesting and promising intervention to develop, but we need to learn more about how to extract the app data, how to make it more personalized, and how to make people make the most of this app. Thanks a lot. And thank you to all those who helped develop the Imaginator app and the intervention.
Thanks, Martina. That was a really fantastic talk. It's amazing to see all the different applications that we can use smartphones for now, especially in the context of, young people who are more likely to be on their phone anyway. It's such an interesting way to sort of flip that on its head and say, okay, how can we use that to help you? So thank you very much for sharing. We have several questions coming in. One from Camille. What do you think of the bidirectional relationship of mental health with some non-communicable diseases, and what can be done to limit this? For example, diabetes is associated with a high risk of depression and even major mental diseases. Likewise, mental disorders may be associated with an increase of risk of diabetes due to medications and stress.
That's a huge question. There is, one way to look at it is, and you might be familiar with, there is new ways of looking at mental health disorders, which is, for example, a possible pathophysiology is via inflammation, and that might explain why there is such a high comorbidity with some other disorders, and why there is such a high morbidity as well in mental health patients. I think, I'm not an expert on this aspect, but I think we need probably to be a bit more creative around how we could tackle both things and help, because and the double stigma in one way. So you mentioned diabetes and maybe depression, and we, at the moment, as physicians, we would look at those separately, and somebody would be seen separately by maybe a mental health practitioner and their doctor to managing the diabetes. I think it'd be a really interesting idea and challenge to think about instead how the two things work together, and how we can address them together.
Some other questions. Do you think that the medical profession is beginning to trust technological solutions more?
I think it depends. It depends on the different layers of the medical profession. I would give you a different answer with my, Imperial College researcher hat on, where I would obviously say yes. But if I go back to my mental health trust, and maybe I'm sitting in a, community mental health team meeting, the answer would be much more skeptical.
What do you think that needs to be done to change that level of skepticism? Is it more evidence, or is it just more ideas coming up through from research to kind of normalize it?
I think we need a little bit. We need more evidence, because for sure there is a bit, like especially if you think of smartphone apps, there is a hype, but there's not good evidence enough. So some of the skepticism is justified, but we also need just to build those bridges. So to bring more of the innovation straight into the, the front line of the mental health practice, because by having access to the technology and using it with the patients, that's when you sort of overcome the skepticism. And also when people start feeling less defensive, because I guess sometimes medics, but other clinicians might be afraid of, like, technology might take our place. And so the first answer is like, oh no, but nothing will replace the face-to-face contact. But that's not the point of using technology. So, yeah.
Did you feel any resistance from the psychiatry field in particular?
Compared to other...
I guess it's hard to say if you're not in other fields, but...
Yeah, I don't know. I would probably imagine, no, it's a guess, but I guess that the resistance is probably more transversal depending on where you work across different areas of medicine.
In neurodegenerative diseases, we've seen, this whole push from the Dementia Research Institute, and they're starting this whole new theme of technological solutions in the home for monitoring patients. So I think we are seeing sort of pockets of innovation coming up through, but I guess you're right, it's just in the fields where there's less evidence or there is mixed evidence, it's hard to place weight on whether or not we should move forward with certain technological applications. But so what's the sort of the next steps for Imaginator, and do you think it will reach a sort of version 2, or are you going to look at other applications?
So the next steps is applying. So I'm currently applying for funding to run a full trial, which would include improving the app, making it more personalized, making it more interactive. But also, I think something that hasn't been done, as far as I know so far, in smartphone-based intervention in psychiatry is looking really sort of, we need to nail the mechanism, is the use of the app, and the use of which function is in the app is related to improvements or side effects of the intervention. We need to understand that, just like we try to do the same with, a drug therapy. That's the next step for any digital intervention, I think, in mental health.
Excellent. I think that's it from questions on our side. So thank you very, very much indeed for taking the time to speak to us, and to following us around all of the different digital platforms we went on today. And we really enjoyed your talk. And yeah, thank you.
Thank you, guys. Thanks for having me. Bye.
Bye. Okay, so next we have David Loughran, who is joining us, I think, from Wales. Let's see if I can add him as a panelist. Ooh. Hi, David.
Hello, hello. Can you see me and hear me?
We can see you and hear you.
Perfect.
Excellent. I've got Eric here, who's going to give you an introduction.
Hi, Eric.
Hello. So everyone, this is David Loughran. He's passionate about supporting individuals to make the best decisions about their health. He's formerly a surgical trainee and an AI clinician for Babylon Health. David is now leads Concentrix Health's mission to empower individuals' abilities to make data-driven health decisions as the company's CEO. Thank you very much for joining us today. David, I'm going to turn it over to you.
Great. So can I, just before I kind of dive into things, maybe from one of you guys, do we have some context of kind of who's in the virtual room? What's the group? And then I can pitch what I'm saying accordingly.
Well, the fantastic thing is, because we are on a virtual platform like this, everyone can just type. So everyone who is watching, in the comments, tell us where you're from and what stage you're at. So PhD student from Imperial College